Now the session is open for discussion, and I would request you to stay back. And among the panelists and chairperson, we have you along with Dr. Saroj Das, Dr. Michel Henry, and we have panelists Dr. Deepak Jain, Dr. Tulio Navarro, and Dr. Nanda Kumar. So I leave it to you, Dr. Parikh, to start the discussion.
I mean, I can talk about the role of the anticoagulants, which is the rivaroxaban in chronic limb ischemia. This is something which has actually, as I said, changed our practice and thinking, and significantly, because we've been using this dual antiplatelet, I mean the aspirin along with low dose rivaroxaban now for almost about 1.5 years, almost 2 years, with significant improvement. So there is in the real world a real place for this therapy. So of course we also had another study which was called the Lighthouse. Basically it wasn't a study, it was just basically a post-marketing surveillance study which is called the Lighthouse project, and that actually had almost about I think over 1,100 patients enrolled in this, with a significant reduction in the limb events. So both these trials have actually, for peripheral interventionalists, given us a huge fillip to our effort to try and reduce limb events. So if there is anything else which anybody would like to add, I'll be happy to continue to talk about it.
I have a question, and I need a comment from Dr. Saroj Das. I mean, he talked very elegantly about the microcirculatory changes after leading to activation of thrombosis after COVID-19 and its impact on venous and arterial system. I wanted his comments and what are the British guidelines for use of this low-dose rivaroxaban, and in patients, especially in patients who underwent peripheral revascularization during this time.
Thank you, Dr. Khanna. As I said in my presentation, that fortunately, the risk of arterial thrombosis is not as frequent as it is with the venous thromboembolism with COVID-19 infection. That's number one. The second thing is that most of the complications of thromboembolism is seen with severe infection. And most of these patients are being managed in the intensive therapeutic unit environment. Apart from this evidence, the so-called recommendation which has been developed is that there is no role for treating these patients aggressively with antithrombotic agents or anticoagulation agents. But what is important in this patient, prophylaxis should remain the mainstay of treatment, and this prophylaxis should be extended to the community environment. If they have developed already, spent some time in the ITU, and subsequently if they have developed any thrombotic episodes. Obviously, if there is a need for limb salvage or there is a need for other rescuing other arterial thrombosis, that should be done as necessary. But most of the recommendation from all the evidence that we have so far is prophylaxis is better, and we should aim at prophylaxis and treat. If the thrombotic episode has caused any significant problem, then we must treat it with therapeutic anticoagulation.
With your permission, can I say something, Dr. Khanna?
Sure, sir.
Yeah. I think I wouldn't agree more. I think Dr. Das has actually put everything in the right perspective. I think it's extremely important to understand the difference between treatment and prophylaxis. I mean, if somebody actually has an event and there's a thrombotic event, then you treat it just as you would treat any other thrombotic event. I mean, whether you start off with in the ITU setting, you probably start off with subcutaneous enoxaparin or low molecular weight heparin, whichever one you want to use. So you continue with that. And then absolutely right, I think this should be continuing in the community setting once these patients are discharged home. We are talking about patients who have severe disease, who did not suffer from any major thrombotic episode, but these patients also, because of the microcirculatory involvement, as Dr. Das said, these patients also need to be prophylaxed, and this also needs to be continuing into for at least about 6 to 8 weeks in the post discharge period, because there is definitely a risk which continues, which really needs to be mitigated. I know there isn't any any evidence to suggest that this should be done, and I know our friend from King's College, Dr. Arya, he, I think, did a study at the King's College Hospital, and they said that there was no real need to extend the prophylaxis beyond hospital discharge. But I think in our practice at the Medanta Hospital in Delhi, and I think major hospitals across Delhi and India, I think there is most of these patients are being discharged on either rivaroxaban 2.5 BD or on Eliquis, which is a apixaban 2.5 BD, for a period of at least about 2 to 3 months, if they have had extensive intensive care therapy and have spent significant time in the intensive care unit because of serious COVID disease.
Thank you very much, and that brings it to the right perspective. Dr. Deepak, we had a question from you because you have an extensive experience in your lab dealing with complications like perforations, which I think are mostly related to undetected calcium or high pressure balloons or maybe oversized balloons. Do you think that IVL, which is intravascular lithotripsy, may be minimizing this sort of complication in very severely calcified lesions and angulated lesions?
Actually, to be honest, I have always relied on rotablator, and since we have been doing rotablators for the last 20 years, I do not feel need, at least in my setting, for anything else to treat calcium except rotablator. But yes, I have seen operators using lithotripsy. We have used lithotripsy in 1 or 2 cases. We had found problems like delivery of the balloon. This was one problem which we found because we are a referral center. We are a tertiary care referral center. We do not have patients walk in. We only have referred patients. So we have a difficult subset of patients. And in those patients, tortuous arteries, severe calcification, the balloon delivery becomes difficult. And for delivery of the lithotripsy balloon, we had to dilate it. And this dilatation was not successful. So ultimately, we come back to the same point. To deliver things, we need to do something. And for that matter, we use rotablator very frequently. So for us, rotablator is the ultimate thing for treating calcified arteries. And we have a very low threshold of doing rotablator atherectomy. In fact, we are doing around 200 rotablators a year. So we have a very low threshold of doing rotablator. So straight away, we go for rotablator right away, electively, and not as a bailout strategy.
Okay, I take your point.
Dr. Khanna, if you allow me, Ivo Petrov speaking. Hello,
yeah, sure.
Hello again.
Yeah, Dr. Petrov, please.
Definitely, for me and for my team, the topic about the lithotripsy, both peripheral and coronary, is extremely interesting. Congratulations for your result that you have shown. I would like to add just detail. So, for example, in very complex lesions in which the so-called non-dilatable lesions, we have seen some stents not dilated in the proper extent, both in peripheral and coronary artery disease. And all we know in such a situation, it's a huge problem for the operator and for the patient. And in this situation, as probably off-label, but it's doable, to put just a non-compliant low-profile balloon in advance, and after that with the lithotripsy balloon, the shockwave balloon, it's possible to disrupt the calcium in order to expand the stent on the proper extent. So we had done 5 cases like this, 2 coronary and 3 non-coronary. One of them was dramatic carotid intervention on a doctor, on a physician. He had total occlusion of the other side, contralateral, and he had critical calcific instant restenosis on the other side, and we succeeded, fortunately, as a final option with the shockwave balloon, and it was a really very, very interesting case, checked by IBUS as well. So it's definitely a new technology that is giving us chance for complex calcific lesions. Thank you.
Yes, definitely, I agree. It's a very good tool, but it has two major disadvantages as of now. One, that it is very costly. I mean, the cost of a balloon as of now probably exceeds the cost of the whole angioplasty procedure with the stent. And it's not reusable, and it has just a life of about 3 hours. You can use it in the same patient and the same size. Otherwise, the chip is so made that you can't use it at a later date. The second thing is in peripheral applications, especially we deal with heavily calcified aorta iliac lesions, and that place the maximum diameter of the lithotripsy balloon which we have is only 7 millimeter, and many a times this becomes undersized, and we are not able to actually break enough calcium or a deep calcium, and we are limited. In aorta-iliac lesions and aorta, you are definitely limited because you can't use this unless you are putting 2 lithotripsy balloons, which becomes very costly, and then sort of trying to break the calcium. So a better strategy, which at our place, a more practical strategy which we use is we endoline first with a covered stent and then dilate at high pressure balloon, and this gives us a much better practical result than using lithotripsy balloons, which are undersized and not getting into the right results which we want.
Totally agree.
Can I ask some questions?
Yeah, Dr. Das, please.
Thank you. This question for Dr. Petrov. Hi, Petrov. Now, in your presentation, you talked about multiple sites radiofrequency ablation of the denervation of the renal artery. Does it have any consequence as regard to the compliance of the renal artery? Does it have a long-term effect with regard to management of hypertension?
Very good question, very important question. In fact, this was the main concern before the widespread use of the renal denervation. In fact, like shown into the multiple trials and also in our experience, we had only one short dissection of the renal artery that was extremely easy piece of cake to be stented. Otherwise, we didn't see any long-term consequence that was unfavorable. As I mentioned, there are some special tiny notches on the X-ray to see the efficiently treated points. And it resulted, these notches, they don't have any further non-beneficial result on the renal artery, and even checked by ultrasound Doppler. Our extremely experienced angiology team is checking every single renal artery after the renal denervation intervention, and we didn't have no one case up to date. And even more, with the new version, the spiral version, I mentioned it's a lower profile on wire system that is absolutely predictable, where the catheter and the delivery of the renal frequency ablation is delivered. So in fact, it's a really very, very safe system.
Thank you. Can I ask another question to Dr. Pratap? I saw that was very interesting, what you presented. Dr. Pratap, I'm talking to Dr. Pratap.
Yes, sir, I'm here.
Yeah. So did you think of putting another stent on the left iliac?
Not really. Actually, we had done a pressure study prior to that, and the pressure difference on the left side was around 18 mean pressure difference was around 18 between the aorta and the left femoral. So we had not thought of putting a stent out there, and it was just out of curiosity that okay, the balloon is pretty much a non-traumatic one. So, and we had a lot of pulses remaining. So we tried, okay, let's see whatever we could make out of it.
Yeah, that's true. But the fact is that your right iliac stent has crossed into the aorta. And there is always a risk that this will definitely compress on the left iliac artery, left common iliac artery. If it hasn't happened now, it will happen very soon. So usually we tend to put what, as you know, the kissing stents in this situation. And so something that is what maybe you have to put this patient under surveillance. He or might need this in future.
Yeah, I'll keep that thing in mind. And the patient is being followed up. It's been around 3 months. He's doing fine, and let's see. Hopefully, he does well in future. If some.
Thank you.
Thank you, sir. Thanks for the.
Thank you.
One question, if I may. Naren, can I ask a question?
Yeah, sure. Go ahead. That would be the last question.
Dr. Petrov, what's your experience with alcohol ablation and ultrasound? Because in our center, we have been increasingly relying on alcohol ablation.
To be fair, we don't have any experience with this kind of renal denervation. I have heard only, and I would be curious to listen to your experience. It really sounds interesting.
Yes, it is. It is very effective, and the best part is it is much less time consuming than radio frequency ablation.
But do you have a special device, or it's
yes, there is a special device for it. Yes, that is true.
So Deepak, may I ask you how, just in the last 15-20 seconds, how do we do it? I mean, and how do we avoid injury to the endothelium and the media? I mean, alcohol ablation just to the superficial nerves, how do you achieve that, and how do you do it? Is it through a drug delivery balloon or something?
Yes, exactly. It's not a drug delivery balloon, but a drug delivery device. It's not a balloon, but a device there which delivers drug, and it has to be given in very small amounts, depending on the response, and the patient has to be anesthetized because it's very painful.
And it doesn't lead to any stenosis or stricture in the renal arteries?
At least for the small follow-up that we have, it didn't. But I do not know. We don't have a longer follow-up.
Because that sounds interesting, and that may be having much wider application than these dedicated, sophisticated devices.
Correct. Yes.
Thank you so much.
In fact, just a detail, we have to know that into the European statement, the two systems that are approved is the the radio frequency and the ultrasound. Unfortunately, so in our environment, the alcohol would be off-label. So it's probably in the future we are going to see more results, and it can be included. So thank you for sharing.
Actually, we are doing under a registry, and it's a phase 3 trial that we are doing.
So thank you, Deepak. Thank you all, Dr. Ivo Petrov, Dr. Raj Pratap, Dr. Das, Dr. Michel Henry, Dr. Rajiv Parak. Thank you for this, deliberation in this interesting session on newer topics in vascular medicine.